What do you do with an esophageal foreign body? We've learned what to do in the event of an airway obstruction, but what if the obstruction doesn't involve the trachea? What if the foreign body is obstructing the esophagus? What then? What causes this, and how will this patient present? What are the important concepts to understand if you encounter this in the field? And how will this ultimately be managed in the hospital? All of these questions will be answered in today's episode. But first, we have sunglasses to give away. Thanks to everyone who filled out our audience survey. Your answers were incredibly helpful for us as we begin to understand how to create more content that helps you achieve your goals of becoming better providers. One lucky person who filled out our survey got a free pair of sunglasses from our sponsor, Frontline Optics. Frontline Optics are sunglasses designed by first responders for first responders. A portion of each of their proceeds goes to a children's charity, and they have a no questions asked replacement policy. So getting a pair of these bad boys is both low risk and contributes to a good cause. If you use the discount code EMSCast15, you can get yourself 15% off a pair of these sweet shades. We did a random drawing giveaway for those who filled out our audience survey during July and August, and we're going to give that pair of sunglasses away today to one lucky participant. Hey, Bjorn.
What's up, man?
Hey, what's up?
How's it going?
It's going well. Which one of you are Ross?
I'm Will.
I'm Ross.
You're Ross. All right. It's cool to put a face to all the podcasts that I've been listening to.
Yeah.
Nice to meet y'all.
Yeah, dude. Thanks for listening so much. It's awesome.
Thanks so much, man, for filling out the survey and participating in the contest. And congratulations on getting the sunglasses.
Yeah, congrats. It's awesome.
Thanks. I appreciate it.
They're awesome sunglasses.
Thank you. They are really nice. I wasn't expecting much, honestly, but I was really impressed. So
give us a little rundown. So where are you working and like what level of training do you have?
So I am in Tampa, Florida. I work for the City of Tampa Fire Department. They make you become a medic in 3 years. So I'm actually in my first 3 years on the department. I'm in paramedic school. I finish in about 8 weeks. So I'm towards the end of the program, but I say a lot of my learning has honestly come from YouTube and podcasts and just self-desire. I was a EMT at a local ambulance company for about 4 years before this. So been in the field for 5-6 years now, and it's where I'm at.
Kudos to you, man, for pouring into it, because I know some agencies where they make it a requirement of employment, it's hard for folks to invest.
Right.
So congratulations on winning the contest and getting the sunglasses. Which sunglasses did you choose? And then what do you think of them now that you have them?
So I got the Pomona Guardian sunglasses. I love them. I was expecting them to come and be like, oh yeah, I won free sunglasses, and kind of expected them to be free sunglasses. But the first thing my wife said when I showed them, she's like, wow, these are really nice. And that's exactly my thought too. I've worn them to the beach. I've worn them on duties multiple times, and these things are tough. They're heavy duty. The polarized clarity is like better than any sunglasses I've ever tried on. So
sick, man.
I'm super impressed, super grateful. Appreciate it, guys.
Yeah, for sure.
Have you gotten them on any, have you been rough on them at all on the job?
I like to say the beach is rougher than the job on sunglasses. But I've worn them on calls. I've worn them on a couple of extrications we were doing. So they've been out, they've been taking a beating, and they look brand new still. So maybe time will put its tell on it, but not right now.
Yeah, and those Pomonas are rated as safety glasses per like OSHA standards and all that. So,
oh, great! I didn't even know that. That's great.
Yeah, well, that's awesome. I'm glad you're enjoying them. And yeah, just like you said, Will and I love them. They're built quality. They're built tough. And if you ever do scratch or break them, you know they got that replacement program. So
no questions asked.
Yeah.
I love it.
Cool, man.
Which is good, because the answers to some of those questions are, well, questionable.
Right.
You lost them where? I fell in the shower and they just ended up there. I don't know.
Yeah.
Right. Well, I'm not planning on losing them or breaking them because I like them. So
Nice, cool,
they
man.
stay with me.
Yeah, for sure. Well, you got our contact info. So as you're finishing up paramedic school, if you ever got any questions, man, shoot it our way. We'd be happy to chat about it. We'd be happy to even make a podcast episode about it. So
Thanks.
For
I
sure.
appreciate that.
I know this sounds a little cliche, but we mean it from the bottom of our heart. Like, we do this for people like you, because when Ross and I were out there on the ambulance, on the street, nothing like this existed. And we just feel so strongly that the people on the street need quality education. So thank you, man. And thanks for what you're doing. And we're going to keep up what we're doing.
You on 8. You on 8. Okay, you're clear. Stand by for your base.
welcome to EMS Cast, where we provide high-level education for you, the providers on the streets.
I'm Ross Orpet. I'm an emergency physician in Southwest Colorado and a former paramedic.
And I'm Will Berry. I am a critical care flight paramedic in North Carolina. Ross, to kick this off, I wanted to start us off with a story. Are you ready?
Yeah, tell me.
Okay, so I was working in Denver, and I was working as a bike medic at a Denver Broncos football game. So we're at Mile High Stadium. It's packed. And when we would work as a bike medic, we were fully ALS equipped as a solo responder. So as things got really busy, it was not uncommon for you to go by yourself on a call. So I got called to a lower section for a choking. And I was a little nervous because all the other bikes were busy and I was going by myself. And the story was coming in that this guy was eating like a kebab skewer with big chunks of meat, and he was choking, and someone was attempting to do the Heimlich. So I'm like pedaling really fast now to get there. I have on my bike, I have a laryngoscope, I have McGill forceps, but I just have me. I get there, this guy is breathing, he's standing up, he's talking to people around him. He is kind of like coughing, gagging a little bit. He has his hand over his sternum and he's kind of rubbing like, oh man, this is just really painful. But he's not choking anymore. So I talk to him. I do a good assessment. The crowd's cheering. It's pretty loud. And as was typical in this setting, we had a first aid room, which was staffed by a emergency medicine physician. And we had some beds where we could kind of hold on to people, work them up a little bit, and then decide later if they needed to transport. So I offered to this guy, I was like, hey man, it's really loud out here. Obviously you're still in some discomfort. Let's go to the first aid room. We have a doctor there. We can let him take a look at you and see what's going on. And he agreed to that, but he said like, it just feels like this piece of meat is just stuck right here. And he kept kind of putting his hand over his sternum. So we get to the first aid room, still in discomfort. Doctor works him up. And do you want me to tell you what he did, or do you want me to hold on to that?
No, tell me what he did. This is a great segue.
Yeah, so what he did was, and this is the first time I'd ever seen this done, is he actually gave him a dose of glucagon. And we administered the glucagon, and then we sat on him a little bit to see if his obstruction would pass, with the understanding of, hey, if you still feel bad at, I don't know, the fourth quarter or whatever, let's send you to the emergency department.
Yeah, this is fascinating. And honestly, not a terribly uncommon scenario either, but doesn't fit our picture of just choked on something, right? He's talking to you, he's breathing fine. You guys are sitting on him, giving him odd medications like glucagon, which we'll talk about whether or not that's the right thing to do. But this all stems from an article on the emsairway.com website that we wanted to cover today. And that article is entitled Friday Night Lights, Shift 9, Steak Night. And this was published on July 8th, 2024. And so if you want to go check out the full article, go over to the website, check that out. And so you and I are going to walk through this article, and along the way, we're going to dissect the topic, dive deeper, provide some evidence-based practices, and give you our own opinions on the topic. As a background, the Friday Night Lights series uses stories from actual scenarios you are likely to encounter, like the one Will did in his past. As it crafts a story of the call, it pauses to break down the mechanisms, the pathophysiology of what you are seeing along the way, as well as how your treatments are likely to help. It's a cool series. Go check it out. Again, emsairway.com. So the article, Shift 9, Steak Night, starts by setting the stage of two paramedics who are competing to see who's going to decide on where to go for dinner when they get a call to a local tavern. This calls for a 64-year-old male with the chief complaint of choking. Will, you get this page, and it sounds like you had a very similar page at the Bronco Stadium. How are you preparing mentally for this call? And when you get on scene, like, what equipment are you going to make sure that you have and that you're bringing from the ambulance into the scene with you?
This is one of those calls that I mentally rehearse for as a paramedic frequently because we can directly save this person's life. If someone is truly choking, like they've obstructed their trachea, and it happened literally right before we get there as paramedics, we have tools where we can reverse that process and save them. It's actually a very impactful call, though kind of few and far between, to really get the true obstructed trachea choking call. What I think about when I'm approaching, I want to make sure I have my laryngoscope. I want to make sure I have my McGill forceps when I get to this patient. I want to make sure I have my suction, my oxygen. Obviously, the other things are going to come too, the kit, the cardiac monitor. But those are the things I'm thinking about right away. I'm anticipating I'm going to be doing something with the airway, and I'm also anticipating that it could get really messy.
Will, before we started this, you were telling me about another story of an actual choking obstruction where paramedics made a life-saving difference at the airport. You want to just run through that really quickly and tell us, like, what pieces, like, what did they do that saved this person's life?
Yeah, this was a phenomenal story of how you can truly impact a patient with this. So it wasn't me, but it was a friend of mine, and this was at Denver International Airport, one of the top 10 busiest airports in the world that we would cover EMS out at the airport. This paramedic was working as a solo responder out on one of the concourses, checking his equipment for the start of his shift, when he got the call for a choking in one of the restaurants. Now, we had the luxury of actually being able to review the security camera footage after the fact, so we actually got to watch the whole call play out. But just as you would anticipate, there was a patron at the restaurant eating a salad with big chunks of steak on it. He started choking on one of the chunks, did the motion to his neck like you would anticipate. Bystanders tried to do the Heimlich, and then the patient actually went unresponsive. He arrives, he opens the airway with the laryngoscope, sees a huge chunk of steak like it was fresh off the salad, barely even chewed. He reaches in, he pulls out the steak with the McGill forceps, and guess what happens right after that? A huge gasp. The patient was actually trying to take a breath. They ended up oxygenating and ventilating this patient. He was hypoxic and he was altered from his hypoxia. They oxygenated him. They ventilated him all the way to the hospital. They did give him a little bit of sedation because he was just so altered from his state. But after a couple days admission in the hospital, discharged fully intact, totally saved, awesome outcome.
And yeah, that is a perfect example of why you started out by saying you mentally rehearse this, and all of our listeners should too. You should be prepared because this is a moment where the things that you do on scene will make a drastic difference in this patient's outcome. And so if you mentally rehearse, what are you going to grab from your ambulance? What are you going to bring on scene? How are you going to move through that airway? You can make a big difference. So I love that idea of mentally rehearsing this. But let's get back to our call here in this article, because we're going to take a little bit of a left-hand turn that we might not expect. So the paramedics arrive and are greeted by the owner of the tavern, who states one of their regulars is choking. And two off-duty first responders who were in the restaurant are currently trying to do the Heimlich, but nothing is coming up. As the paramedics make it into the tavern and to the patient, they see two people attempting to perform the Heimlich on an upright man who is making a weird sound, making that gesture of I'm choking, and coughing all in one. You notice a plate next to him with a half-eaten steak. What's on your mind right now?
Yeah, I mean, this totally seems completely plausible, like we've just outlined with real stories that I know firsthand. I'm assuming he's still conscious, so I'm still nervous, but I'm thinking about the next things I need to get done, which is his airway still compromised or obstructed? Has he aspirated anything? Is there potentially injury to his lung now? Like, just because the obstruction has been relieved in his trachea, an aspiration injury can also cause some acute problems we may need to deal with. And then I'm thinking oxygenation, ventilation, and essentially commencing with my general patient assessment. I've gone from thinking, oh my God, I need to snap into action and save this person's life, to let's take a breath and let's figure out what's going on.
Yeah, exactly. Just as you pointed out, the fact that this man is still conscious between however long it took you to get from your station to the scene while he's been choking that whole time is somewhat reassuring that he's at least getting some oxygen to stay awake. So as you're thinking about all this, the choking man looks at you and says out loud with a totally clear tone and in a full sentence without any pause or respiratory stress that I cannot breathe.
Well, that doesn't really make any sense. Our vocal cords, top of the trachea, they require air movement to vibrate them and produce sound. So if he had truly aspirated steak and had a tracheal obstruction, he wouldn't be able to communicate with a clear tone of voice.
Right, exactly. Your thinking is spot on. This is weird. Doesn't make sense. So what do you do now?
I want to start reassuring him, collecting some history, figure out the events from the bystanders. I guess even the patient, since he can talk to me, can answer some of my questions. I want to listen to his lungs. Are there any lung sounds that I want to know about, like wheezes, and any evidence of stridor if I auscultate around his trachea?
Great. I totally agree with this approach. Based on the description, he is awake with good color, does not appear to be in any imminent respiratory distress, and is speaking in full, clear sentences. Based on this, there are no immediate life threats that appear that they need to be addressed. You may listen to the lungs and for stridor real quick just to further confirm there's no, immediate compromise to the respiratory syndrome that needs your attention and addressing. And if you got time, you can have your partner get you a set of vitals. And the most important thing, as you mentioned, is in the history. Most often, the answer to the puzzle of what's going on is found in the history. So you start interviewing the patient's wife, who is at the table. She's able to tell you that he was quickly trying to finish his steak in order to make it to the movie theater for a movie they were about to see, and they were running a little late, when all of a sudden he started gagging and dry heaving. You ask the patient if he's feeling any better, and he tells you, no, I don't feel any better. He also tells you he's having some chest discomfort, points to his mid-sternal, kind of second intercostal space. And you're right as he's telling you this, your partner starts hooking him up to the 12 lead, and you listen to the side of his neck. You hear totally clear air movement without any stridor. You ask him to swallow, and he does that without any difficulty. And you listen to his lungs, and they're clear throughout. Your partner hands you a 12 lead that just looks like sinus tachycardia at 118 without any ischemic changes. And the patient comments, I still feel like I'm choking. What the heck is going on? This patient he's clearly symptomatic. He keeps gagging and dry heaving. He tells you he feels like he's choking, yet he's talking in full sentences and moving air without any problems.
Well, the first thing is this story, I'm excited to see what knowledge bomb you're going to drop on me, because this is exactly what happened in my real story. I'm worried right now that he did have a chunk of steak in his trachea. During all of this, it became dislodged, which means it went into like the back of his oropharynx, his mouth, where he could like kind of taste it again. And he swallowed it into his esophagus, and now it's like kind of stuck there. What do you think about that?
So the author of the article calls this steakhouse syndrome, which I had actually never heard this term before, but looking it up, it is actually a common way to refer to this condition due to the fact that the culprit is often steak. But what this is in medical terms is an esophageal food impaction. So not a tracheal obstruction, but an esophageal GI tract obstruction. And like you said, maybe somebody aspirated, coughed it up, and then it got stuck in their esophagus, but that doesn't always have to happen either. They can be eating too quickly, not chewing well enough, and have a big food bolus that they swallow, and then for some reason can't make it through the esophagus. Often the patient will have a history of this happening to them before. Although probably most people who this has happened to before probably won't call 911. They'll probably be well-versed enough to try various things at home and then reluctantly come to the emergency department after a period of time, kind of hanging their head with an air of failure because they hate that they had to come back again for this. At least this is my most common experience with how these patients present to my emergency department.
First off, how has this never happened to Joey Chestnut, the world famous hot dog eating champion?
That is a great question. Lots of water, I guess.
I guess so. Also, little street tip. I have no data to support this, but if these patients are in a public setting and they do end up vomiting a little bit, or they're choking, or it has been some sort of a scene, anecdotally, I've heard of these patients wanting to go to the bathroom to clean themselves up, and then sometimes they choke again alone in the bathroom. So following your patient there, keeping a good contact with them is important. To the story, I really want to dive into why this happens. Ross, when do we need to worry about it? And what gets done to treat this esophageal impaction?
Yeah, so we'll talk about what the various treatment options are. And obviously in your story, you guys gave glucagon. And we'll talk about the risk benefits to that. But first, let's talk about why this happens. So the classic story is eating meat. It's almost always meat. I've had patients come in telling me it was a bagel or a cinnamon roll before, but at the end of the day, when they put a scope in, a camera down the esophagus to remove it, it was actually a piece of meat. 99.999% of the time, it's a piece of meat. The reason is that most other organic material will kind of soften over time with moisture, saliva, and eventually just break down and pass on their own. Whereas a piece of meat will not. It's a really fibrous, tough tissue. So usually people were eating too quickly and not chewing their food enough. And in fact, when this happens to people, part of their discharge instructions always involves instructions on cutting meat into very small bites and an abundance of chewing before they swallow. This will be the most classic story of how this occurs, is just eating too quickly, not chewing, not cutting your meat small enough. And again, this is the method of prevention. But most food bolus impactions are accompanied by some underlying component of pathology, either mechanical or functional. In terms of mechanical etiologies, strictures or a narrowing of the esophagus is most commonly caused by what's called a Schottky ring, or a peptic stricture, or an eosinophilic esophagitis. In terms of functional etiologies, this occurs with motility disorders, which cause diffuse motor abnormalities of the esophagus, or an esophageal spasm can cause a transient food bolus impaction. In these patients, the impaction generally passes after a period of relaxation where the muscles of the esophagus are no longer constricted and allow the bolus to pass.
Ross, in your experience, do patients know if they have any of these mechanical etiologies of their esophagus?
So usually in my experience, the vast majority of these patients that I've seen with this do, because it's happened to them before, and then somebody sticks a scope down, retrieves it, and then takes a look at it. And the vast majority are not functional. Most of them are mechanical. They have some sort of stricture or narrowing because of one of the things I talked about, the Schottky ring, a peptic stricture, or the eosinophilic esophagitis, which is just some inflammation in the esophagus that causes a narrowing. And when there's a narrowing there, if you have this piece of meat that's thick, fibrous, tough, that hasn't been chewed or cut appropriately, it can get stuck in that narrowing in the esophagus. And they're aware of this because they've had scopes before, they've had to have treatments like balloon dilations, and they're able to tell you, yep, this is happening again.
Gotcha. So question then, I'm thinking through like how and why somebody gags. If the impaction is in their esophagus, why would they cough or gag or have the sensation that they're choking?
Let's break it down with a little bit of anatomy, and I'll get to the theory. So the trachea is made of this fibroelastic tissue. It's flexible but kind of sturdy material that connects these cartilaginous rings. These provide your support and give you that kind of corrugated pipe type structure. These rings, again, are fibroelastic tissue, and they make up the front half of the trachea, with the posterior portion formed and connected by the trachealis muscle. And there's a picture of this in the article. So again, go to emsairway.com and check out this article.
Well, also, I like to point out, if you're listening, just put your fingers up on your neck and you can feel your tracheal rings. And then imagine that if you could feel your trachea from like inside your neck, you wouldn't feel those rings, right?
Yeah, totally. Exactly. Because the back portion of that is made by muscle tissue. And so this trachealis muscle houses these stretch receptors, which help trigger kind of that choking reflex and cough when we aspirate something, because we don't want foreign materials to go into our lungs, cause all kinds of problems, pneumonia. And so that stretch reflex gets activated. We start gagging, coughing, and that sensation of we're choking is that reflex to prevent material from getting into our lungs. Whereas the esophagus is a flexible, kind of loose tissue that mainly uses gravity and then some peristalsis of smooth muscle fibers to move food down the esophagus into the stomach. The esophagus now sits right behind that trachealis muscle in the chest. So there's this thought that what can happen is if food becomes impacted or stuck at just the right spot in the esophagus, it can stretch that trachealis muscle and trigger kind of that choking reflex that causes the gagging reflex, the sensation that you're choking. Now, I will say most often people are just sitting there telling me they feel like they have steak stuck in their esophagus. They can tolerate their own secretions, but anytime you try to get them to drink anything, they just vomit it right back up because they can't get past that food bolus impaction. And so most of the time I don't see this kind of choking, gagging reflex. Sometimes I'll see them like, I don't want to swallow my spit because it's uncomfortable. So they're like spitting their spit into a bag. And anytime you try to make them drink anything, they'll vomit that up. But if they are gagging, that's kind of the thought behind why this occurs.
Okay, so if there's an impaction in their esophagus and it's essentially obstructing it to the point that it's putting pressure on this trachealis muscle, causing this gag reflex, how do you treat this? Obviously, I know you mentioned scope, so they can physically put something down there, I suppose, but what else can happen?
Yeah, so first and foremost, we'll assess for their ventilatory status and airway patency. And this is our main job in the field, right? Is to assure there are no life threats. And if there are, just treat accordingly to the threat. But assuming this is just an esophageal foreign body and not an aspiration, airway and breathing is generally not compromised. However, if the patient is unable to manage their own secretions, they are definitely at high risk for aspiration. And so these patients need to be managed a little more urgently. And our job at this point is essentially to keep the patient comfortable and limit the risk of aspiration. So you're going to treat nausea if they have it. You're going to avoid trying to get them to drink anything. And again, like you said, and like I mentioned earlier, the definitive treatment is endoscopic management, where general surgery or GI will sedate the patient and pass an endoscope, which is just a camera on a long tube, and they will identify the impaction, and they'll do one of two things. They'll either push the impaction forward into the stomach, or they'll use a tool to snag the bolus and pull it out. When doing this procedure, there are some risks, and the risks involved in this procedure are mechanical perforation or tear of the esophagus. But we know that even outside doing the procedure itself, impactions that last longer than 12 to 24 hours increase the risk of spontaneous perforation.
Wow.
The risk of perforation from prolonged food bolus impaction is thought to be secondary to this like pressure necrosis of the esophageal soft tissue. So this is somewhat of an urgent time sensitive thing if somebody has one of these food bolus impactions. Now it's not emergent, it's not like lights and sirens, but it's urgent in that it needs to be treated in kind of the next 12 to 24 hours. And they do need to go to the emergency department for evaluation.
What about if they have the sensation that the bolus is moving slowly down? Like, let's say their esophagus is doing, I guess, what it's supposed to through peristalsis. Is that sensation usually accurate for them? Like, are they really feeling that move, or should we just not worry about that?
It might be. I mean, the truth is the vast majority of these will pass on their own without any sort of procedure. And patients who have had this happen before learn that. And so oftentimes when they come to the emergency department to see me and they've had this happen before and they're like, I know what's going on, they've spent some time at home trying to do various things to get it to pass on its own, and it hasn't. And historically, we have tried a lot of different tricks in the emergency department in an attempt to get this to pass on its own without having to do like an endoscopic treatment. Now, these have included things like Coca-Cola or Alka-Seltzer, with this belief that carbonation or maybe acidity may help soften the impaction and allow it to pass. And we've even tried medications like you did in your case, such as glucagon, nitroglycerin, or diazepam, with the idea that these medications relax the smooth muscle of the esophagus. And if you relax that muscle, they may allow the food to pass.
Seems reasonable in thought.
It does, but unfortunately, none of these medications have been proven to be effective in scientific studies. In my experience, glucagon and cola are the two most commonly attempted modalities. So I'll highlight studies addressing each of these. One was published in the British Medical Journal in December 2023, and it was entitled The Efficacy of Cola Ingestion for Esophageal Food Bolus Impaction, open label, multi-center randomized controlled trial.
So Ross, you're an emergency room physician. I mean, as a paramedic, I'm like, I want to try the cool thing to try to like be the hero to save the day. If you administer one of these patients glucagon or Coca-Cola, do your colleagues at GI think you're a fool, or are they like, oh, right on, this guy's actually trying something?
Yeah. So
do they want you to try these things before you call them, or what?
It's gonna depend on the GI doc, and I'm gonna tell you the right answer, and then I'll tell you what happens in the real world. So the right answer is, as I said before, what we don't want is this patient to aspirate. And so if we give them liquid to drink, and there's a complete obstruction of their esophagus, that liquid can't get past the obstruction, so it has no other place to go other than up. And that, if they vomit, increases their risk of aspiration. Glucagon, similarly, we'll get to the data in a second, increases your nausea and vomiting. If anybody's ever given glucagon in the field, it may improve your blood sugar, but it has the side effect of making you feel nauseous. And so both of those are going to increase your risk of aspiration, which is the one thing we don't want to happen. I will say, in the real world, a lot of GI docs, unfortunately, will still make you try one of these tricks. And not the cola. I don't think they believe in that as much. But they'll usually make you try some sort of medication because that's medical, right?
So we kind of left on a cliffhanger. So, I mean, does it work? What did the study say?
Yeah, so the GI docs may make you do it. And I will say, where I practice currently, thank God they do not. But the studies, what the scientific data show, there was this 2023 study looking at cola. It was by TB et al. They had 51 patients who presented with an acute food bolus impaction. 28 of those patients were randomized to drinking cola. 23 were randomized to observation of spontaneous passage. There was no difference in the rate of passage, with 61% spontaneously passing in the cola group and 61% spontaneously passing in the observation control group. So absolutely no difference between the groups. Now, with regards to glucagon, which I will say I have been told to give more often than not by GI providers, there was a paper published in Pharmacology, February of 2019, entitled Glucagon for Relief of Acute Esophageal Foreign Bodies and Food Impactions, a systematic review and meta-analysis by Pexa et al. This was an analysis of retrospective, observational, and randomized controlled trials that were published before March 1st, 2018 that assessed glucagon for relief of acute esophageal foreign body and food impactions. 5 studies with a total of nearly 1,200 patients were identified by their search, and treatment success occurred in 30.2% of the patients in the glucagon group and 33% of patients in the control group. So statistically, no difference in treatment success.
Wow.
But they also evaluated adverse events, which occurred in 15% of the glucagon group and 0% of the control group.
Assuming I'm thinking back to that side effect you were talking about?
Exactly. The adverse that was most commonly identified was vomiting, which is a known side effect of glucagon. So take home from this study, glucagon was not associated with a difference in treatment success, but had a higher rate of adverse events for the treatment of esophageal foreign body and food impaction.
Interesting.
So there's no evidence that any of these medications or tricks work. The same is true for Valium. It hasn't been shown to work in scientific studies. But again, don't be surprised if you take one of these patients to your local ED and you still see they end up trying one of these medications. In my mind, this is mostly just a stall tactic to try and see if the impaction will pass on its own. Because oftentimes with time, it does just pass on its own. And like I said before, this is urgent, not emergent. Patients who can tolerate PO may only have a partial impaction. So if they're tolerating their own secretions, they can sip on a small amount of water. This may only be a partial impaction. And these patients may be able to be managed as an outpatient, as again, they'll likely pass on their own. However, if they cannot tolerate PO,
most guidelines note that every attempt should be made to perform endoscopy retrieval within 24 hours, as rates of successful removal and risks of complications such as perforation increase after this period.
In addition, if the patient is unable to tolerate their own secretions, like I said before, they are considered high risk for aspiration.
And endoscopy should be performed as soon as possible, ideally within 6 hours.
If they identify a stricture or that narrowing of the esophagus, they may perform what's called a balloon dilation, either during the procedure or at a later date. And patients, like I said, are at risk for having these kind of recur.
Nice. So thinking back to the case, the one I had, but then also the one that set up this article, which is the guys in the tavern. Let's say the patient's talking, but they're not managing their own secretions. So let's think about what that really looks like. They might have a little bit of vomit. They might have a lot of saliva. They might try to drink water, but then all of it, they spit it all back out. I mean, these are people that when you're interacting with them, that's not normal. It's not going to look well, and it's probably going to make you still have a little bit of pucker factor. So they're going to go to the hospital. And I think you should press for them to go with you. Remember, we're talking about these esophageal impactions. They're pretty much diagnosed, like it's for sure confirmed with the endoscopy. There still could be something in their trachea. We don't know. So act in the best interest of your patient and monitor them. It's still a potential airway problem until proven otherwise.
Yeah, exactly. And again, high risk for aspiration, which causes more problems, pneumonia, all of those things. So yeah, these patients need to go to the emergency department, and airway monitoring on the way is a necessity.
Thanks, Ross. I have always been curious about the glucagon thing. That's a party trick I had always heard of, seen it done that one time, and I've been curious.
Yeah, someday we'll no longer be doing that silly trick, but don't be surprised if you still see it in your local emergency department.